colleagues, a very warm welcome to this afternoon session, Unveiling the Hidden Threat, Recognizing Undiagnosed Heart Failure in Women, sponsored by OMRON Healthcare Europe, BV. And it's a great pleasure to have you here and to have with me Alta Schutte, Professor of Cardiovascular Medicine at the George Institute for Global Health in Sydney, Australia, and Eva Gerdts, Professor of Cardiology from Bergen in Norway. And my name is Renate Schnabel from Hamburg University. And it's a pleasure to immediately start with the most important question, bias in cardiovascular care. Why is cardiovascular disease often missed in women? Alta, please.
Thank you very much, Renate, and also to the audience. I think this is a very important session. I would like to thank OMRON also for the invitation to be here today. So I will be speaking on bias in cardiovascular care and why cardiovascular disease is often missed in women. And these are my disclosures. In 2021, the Lancet actually commissioned the Lancet Women and Cardiovascular Disease Commission, and they have really highlighted again how important it is that we recognize that cardiovascular disease is the leading cause of death also in women. 35% of all deaths are caused by cardiovascular disease in women. And what is really importantly demonstrated by the Lancet Commission is that cardiovascular disease among women is understudied, under-recognized, underdiagnosed, undertreated, and women are often underrepresented in clinical trials. So I'll dive into that a little bit and to explain also why potentially women with cardiovascular disease are often missed. So this great paper by my colleague Mark Woodward on cardiovascular disease and female disadvantage, he clearly said CVD is not a man's disease. There's often this perception, but indeed it's arguably the most important disease amongst women globally, and despite this, its importance in women is insufficiently recognized. Addressing this gap requires a fundamental change in the way we view women's health. And if we think about cardiovascular disease being understudied, we have to think also about how cardiovascular disease is treated. And based on all of our clinical management guidelines, which is the go-to place for every clinician, is how to treat any cardiovascular disease, we have to think where these guidelines come from. So we know very strongly basing cardiovascular or recommendations in these guidelines on randomized clinical trial data, whereas before that we often have clinical and population-based studies where you do observations in terms of risk factors and management of cardiovascular disease, which is often underpinned by earlier studies, preclinical and discovery research in tissues, animal work, which go back all the way to molecular research, genetic research, and cellular research, right? So this is a whole pipeline of research that we have to consider on the bias of cardiovascular disease management in women. If we first look at molecular research, for example, we have to be considering in vitro models, and also sex needs to be considered in these studies, because sex effects begins already at development if you think about the sex-determining gene found on Y chromosomes, which dictates sexual development of sexual organs, but also much broader than that, that sex hormones regulate ion functions, channel functions, which is a key aspect of cardiovascular electrophysiology, and that's already embedded in our cells, and therefore important for transcriptional regulation. Also, we know in adolescence already there's a sexual difference in terms of how cardiac muscle is developed in males and females in adolescence. So it stretches from early days onwards. But if we look at cardiovascular research in primary cell lines, we can see that most papers don't actually report the sex of the original cells. 28% of articles who did report it found that almost 70% only used male cells, whereas no groups used exclusively female cells. So it's an overrepresentation of male cells. You wouldn't really think about that, but it is very important in understanding basic physiology, and there may be differences based on different hormones and influencing, for example, the ion channels, as I've mentioned. If we move then towards preclinical and discovery research in animal models, it was shown as well for cardiovascular mouse studies. Both sexes were reported to use a similar rate of all disciplines combined, but male dominance is more pronounced in this discipline, with nearly half of studies using only male mice. Once again, that translates all the way from cellular to animal models and tissues. And when it comes to clinical and population studies, in the US, for example, the NIH have already recognized this as a big problem, and in 1994 published specific guidelines for research to include, equal sexes in research, whether it's from cells to humans. Whereas in the UK, this was only recognized in 2020, and still, despite that, the progress on uptake is unacceptably slow. Let's have a look at randomized clinical trials. And there was a review on the participation in women in cardiovascular clinical trials, looking at the proportion of women in these trials represented by the prevalence of these cardiovascular diseases in women. So it's a prevalence-corrected estimate. So I don't know if you can see clearly on the screen, but from statin trials all the way through to the bottom of drug trials in pulmonary hypertension, you ideally want representation to be in this green block, but you can see almost all the trials, from statins, cardiovascular device trials. We're referring today also to trials in heart failure or heart failure specifically, drug trials from PCSK9 drugs, all of them underrepresentation of women in those clinical trials. It's only for hypertension, atrial fibrillation, and overrepresentation for drug trials in pulmonary hypertension that we see women represented. What about women as authors in trials, in clinical trials? And you can see there the red representing women as lead authors first and last in the top box, and then women as first authors only in red, or then representation of women in clinical trial, all authors. You can clearly see there's an underrepresentation of women there. And there may be several reasons for that, but that does bring to the fore that there's nobody to speak for specific aspects related to an analysis that focus on women specifically. So there will be an excellent presentation, I'm sure, by my colleague following me on heart failure in women. But if we look at inclusion of women as participants in heart failure clinical trials over time, and I just looked at trials published in the New England Journal of Medicine before the year 2000, you can see that from small to large studies, 87% and above were men. So there were clearly underrepresentation of women in all of those trials. But since 2019 onwards, the more recent trials, you can see there is, unfortunately for the dapagliflozin trial, still 76% represented by men. But after that, there seems to be a shifting change where you can see around 44 to 55% of men and women equally distributed. But so there is a recent shift, which is a great sign to make sure that women are represented in these studies. Of course, also women as authors and clinical management guidelines. How has things changed there? And just took an example for the hypertension guidelines for Europe. You can see the 2013 guidelines more than 10 years ago. Only 3 of the 25 authors were women. 12%, where 10 years later the ESH guidelines were updated, that were 22% as women, so there is progress, whereas the ESC guidelines, which were published last year, did pretty well with 48%, which I think was a deliberate action also by the ESC to recognize this as a key factor to move forward with. Then women as physicians. This is something we really have to recognize as well. And this specific example here was female physicians and male physicians, which was in the Florida emergency departments. And the graph shows a probability of survival from cardiac treatment. And you can see female physicians actually performing pretty well, but both for males and female physicians, there's better survival among male patients. So there is this continued bias, whether there's a female physician or a male physician. But it's really important to recognize why we often see underrepresentation of women as authors in clinical trials of research studies is that only 13% of practicing cardiologists are women. And if you look at interventional cardiologists, it's only 4.5%. We see this at this meeting as well. There's often, this is the real world situation, and often that is reflected also in development of steering committees, clinical trials, and also research being investigated. But since we are aware of it, there should be, I think, also a clear acknowledgement that we need to do better. So Throughout the whole pipeline of research, I think it is important that we need to make sure that there's inclusion from female cell lines, animals, research participants, from population studies, randomized clinical trials, also researchers, guideline writers, and physicians treating patients. We need to work towards a better representation there. And in these green boxes, also importantly, other studies have found that because women are less represented all the way through from that baseline, from cells and into research and clinical guidelines, there's a lesser understanding of risk factors in women or how they present when, for example, coming to the emergency department with a cardiac condition, and therefore the time to diagnosis in women is much longer than what we've seen for men. And there's a lower likelihood for women to be offered aggressive treatment than they would be for a male patient. So these are some of the real-world observations we can make. So as my final slide and takeaway, I do think it's very clear that sex and gender bias is deeply rooted in numerous elements of cardiovascular research. We need a clear recognition of that and significantly improve our understanding of cardiovascular health in women. But despite improvements, we see, fortunately, there are improvements. We still have a long way to go. And I just want to highlight also this reality of what happened in the past and how that still affects what we do today, is if those of you are familiar still with the Mr. Fit study, the US multiple risk factor intervention trial, which was done in the 70s, that study screened 325,000 men, but no women, for risk factors for cardiovascular disease, and identified several factors that are still used today and still relied on in terms of clinical guidelines, research development. So there's an inherent, lag of how we move forward in terms of understanding cardiovascular health in women, but good to see some progress in recent years. Thank you very much.
Thank you, Alta. So some improvement, but still a big gap. I think we have a discussion at the end, and therefore, if there are no burning questions, we would directly move on to the topic of risks and symptoms in female heart failure. And data will be presented by Eva Gerdts, professor in cardiology from Bergen University in Norway. Eva, please.
Yes, thank you very much for your introduction and also for the invitation to talk to you today. And these are my disclosures. Sex differences are well documented in most aspects of heart failure, in etiology, in risk factors, in pathophysiology, comorbidities, as well as in heart failure phenotypes and in prognosis. And as the title says, I will focus mostly on differences in risk factors and symptoms. So if we look at a recent publication from the PREVENT cohort in Groningen in the Netherlands, they follow this community-based cohort, 8,558 women and men, for 25 years of follow-up, and for development of heart failure with reduced ejection fraction, HFrEF, and heart failure with preserved ejection fraction, HFpEF. And what they found was that the lifetime risk of heart failure in general is the same in women and men, and they found that this was 24%. But if you look in the upper corner, you see here on your right side that although it was 24% in both genders, men had threefold higher risk of HFrEF, while the risk in women for heart failure was equal for HFrEF and HFpEF. So also they identified 8 risk factors, traditionals, and comorbidities, and looked at the population attributable fraction of these factors. And they looked at hypertension, smoking, obesity, hypercholesterolemia, and diabetes mellitus, all well-known risk factors for heart failure, and the comorbidities myocardial infarction, atrial fibrillation, and chronic kidney disease. And what they found, you can see in the lower right corner of this slide, they found that these 8 factors contributed more to explain heart failure in women than in men, and this was true both for heart failure with preserved and reduced ejection fraction. When we look to the Swedish heart failure registry, this study was based on nearly 43,000 women and men, covering 54% of prevalent heart failure in Sweden at the time between 2000 and 2012. And they looked at what is the percentage of women in the 3 different subtypes of heart failure. And as you can see in the figure, that women constituted 29% of patients with HFrEF, 39% of patients with heart failure with mid-range ejection fraction, and 55% of patients with heart failure with preserved ejection fraction. Women also had better prognosis in all these heart failure subtypes. And if we look into their numbers, you see that women had 20% lower risk of death, this was all-cause mortality, and heart failure hospitalization over 12 years in the group of HFrEF. In the group of heart failure with mid-range ejection fraction and heart failure with preserved ejection fraction, 9 and 7% lower event, all-cause mortality combined with heart failure hospitalization in women compared to men. And this is despite women being older, having more hypertension, more comorbidities, including lower renal function in heart failure. So this table I took from the current guidelines of heart failure issued by the European Society of Cardiology in 2021. And here we have listed the typical symptoms of heart failure, like dyspnea, like fatigue, reduced exercise tolerance, and ankle swellings. And what we find in women with heart failure is, in general, they are more symptomatic, but it is particularly orthopnea and paroxysmal nocturnal dyspnea that is more commonly reported by female patients. Heart failure symptoms are often more neglected both by patients and also by health providers in women compared to men. So you can think about a quite typical female patient with heart failure. She is obese, she is older or elderly, she has knee and hip problems, she is not very physically active, and of course this woman has long time ago explained her dyspnea from these comorbidities and this lifestyle. And the GP might play along with this, and she will not be referred for specialized health care. And this is quite common in Norway, and I'm sure it's quite common where you practice. Traditional risk factors like hypertension, diabetes, smoking, and obesity all have a relative higher risk for heart failure. Hypertension, 3-fold higher risk of heart failure, 2-fold in men. Diabetes, 5-fold higher relative risk in women compared to 2-fold in men. Obesity, particularly strong risk factor for HFpEF in women, and smoking also stronger and more potent risk factor in female patients versus males. But in women, there are also quite a few untraditional or non-traditional and female-specific risk factors. This has been a focus of many recent publications. So think about iron deficiency and anemia, quite common in women, and it affects immune function and cell metabolism. Think about autoimmune diseases. 7 out of 10 patients with these disorders is female. So this is associated with a chronic systemic cardiovascular inflammation. And think about pregnancy complications, the most investigated preeclampsia, which induces a chronic systemic cardiovascular inflammation that doesn't go away after delivery. So this promotes early hypertension and early cardiovascular disease in these women. And preeclampsia, it affects 3 to 5% of all pregnancy, so it's not very rare. In this study, a Mendelian randomization study based on data in the Women's Health Initiative, they looked at associations of the adverse pregnancy outcomes with heart failure. And as you can see in the graph, gestational diabetes, low or high birth weight, or preterm delivery were not associated with increased risk of heart failure. But hypertensive disorders of pregnancy were associated with a 75% higher risk of heart failure, also when adjusted for traditional risk factors. And what is interesting is that 2/3 of this risk was explained or attributed to hypertension, increased body mass index, and coronary artery disease. But 1/3 was attributed to having a hypertensive disorder of pregnancy itself. A quite recent publication came out now in Heart, and this was based on the women in the UK Biobank study, and it looked at the population attributable fraction of heart failure risk factors. And these women, more than 233,000, were followed for nearly 14 years, and they assessed 22 specified risk factors that were grouped into traditional, to female-specific, and under-recognized. And the female-specific included early age, at menarche, at first birth, at menopause, or pregnancy complication, and chronic inflammatory disease. The under-recognized risk factors included depression, anxiety, low socioeconomic status, high deprivation, and air pollution measured by PM2.5 level. I was invited to comment on this in an editorial that just came out, and we looked at the spectrum and attributable burden of risk factors for heart failure, and we summed this up in this figure. So in the UK Biobank, 46% of heart failure was explained by traditional risk factors, while 15.5% was explained by female-specific risk factors, and 25.5% by under-recognized risk factors. So to me, this points to that heart failure is more difficult to prevent in women, and also maybe more difficult to treat. So, Chair, ladies and gentlemen, these are the key messages. The lifetime heart failure risk is similar in women and men, but women are less likely to develop HFrEF and more likely to develop HFpEF. Women have better prognosis irrespective of the type of heart failure, but they are more symptomatic. Traditional risk factors and comorbidity may explain up to 60 or 70% of female heart failure risk in recent publications, while female-specific and under-recognized risk factors might explain up to 40% of female heart failure risk. So I thank you very much for your attention.
Thank you very much, Eva.
Okay, so then it's my pleasure to introduce the last speaker in the session, and Renate Schnabel. She is professor of cardiology at Hamburg University, and we are looking very much forward to hearing your talk before the discussion.
Yes. And I will now switch to atrial fibrillation, and very closely related to heart failure and how early atrial fibrillation detection can improve outcomes. So we all know that atrial fibrillation is a disease of the elderly individual, and that there is a delay in atrial fibrillation onset in women about 10 years. But if you get only old enough, similar to heart failure, women and men will develop atrial fibrillation 1 out of 3 individuals. As I said, and more data will be presented to you on one of the late breakers, that atrial fibrillation onset in women is later, here 71 years in the median, compared to 67 years in men. Again, one of the strongest risk factors of atrial fibrillation is hypertension. Here you see 2 peaks, individuals with developing atrial fibrillation and without, and those developing atrial fibrillation have a significantly higher baseline blood pressure across European cohorts. Also, the population attributable fraction is significant, and it's one of the highest population attributable risk fractions for classical risk factors. And we all know that hypertension is related to stroke, similar to other risk factors, and the pathways for cardioembolic stroke are complex, but we think that they go through cardiovascular dysfunction, lifetime impact of cardiovascular risk factors, atrial cardiomyopathy, and then atrial fibrillation is a good marker, possibly also a causal factor for cardioembolic stroke in individuals with hypertension, obesity, and other cardiovascular risk factors. How do we see atrial fibrillation? The classical way is clinically detected atrial fibrillation, like symptomatic patients, post-stroke, post-surgery, or other diseases as secondary or triggered atrial fibrillation. But increasingly, we're able to detect atrial fibrillation early. This can be by implanted cardiac devices. This can be by intensified screening. But this can also be by consumers, by people starting to screen themselves for atrial fibrillation. This also provides some opportunities. If we detect atrial fibrillation early, we can not only prevent stroke, but we can possibly also prevent the substrate and modify the substrate. This is why I talked about atrial cardiomyopathy, and we can manage risk factors and comorbidities. We can perform rhythm control and anticoagulation, and thus maybe reduce the progression of the disease. And this means, shown in this slide, that the risk-benefit ratio of oral anticoagulation for stroke in the beginning for early atrial fibrillation is probably not very high. But when we detect atrial fibrillation early, we have the ability to prevent progression, and we are often better at rhythm control. The complex mechanisms behind that include calcium handling abnormalities, ion channel dysfunction, autonomic neurocontrol, and structural remodeling. If addressed early, we can reduce these triggers of focal ectopic firing and reduce the re-entry prone substrate. We all know that the natural history of atrial fibrillation is paroxysmal atrial fibrillation, 2 more persistent types of atrial fibrillation, depending on the individuum, and we have a progression rate here on average of 7% per year, clinically detected atrial fibrillation. We You also have device-detected atrial fibrillation, increasing numbers we see here. And here we also have the opportunity even earlier, this is subclinical atrial fibrillation often, to modify the atrial substrate, in particular through management of risk factors and cardiovascular comorbidities. And what is here again, the number is similar, 7 to 9% of device-detected atrial fibrillation convert into clinically detected atrial fibrillation per patient year. In whereas we have highest stroke rates in individuals with persistent and permanent atrial fibrillation, this is much lower in paroxysmal atrial fibrillation, and here you see in device-detected atrial fibrillation very low stroke rates, about 1% per year. But still, two large trials, the Artesia study and the NOAA-AFNET6 study, addressed this issue. And in the large Artesia trial on the left-hand side, you see that apixaban treatment of early atrial fibrillation, device-detected atrial fibrillation, had a significant benefit for stroke outcomes. The NOAA-AFNET6 smaller study was terminated early due to fertility, but you can see that the curves appear to be similar. So with early detection of atrial fibrillation, be it through medical in the medical system, be it through atrial fibrillation screening efforts, or through consumer-detected atrial fibrillation, gives us the opportunity to check for comorbidities and manage lifestyle and risk factors. And with that, this is a recent expert statement from the AF Screen International Collaboration, we have the opportunity to probably reduce progression of cardiomyopathy and thus reduce or slow the progression of atrial fibrillation towards more persistent types of atrial fibrillation, and importantly, very likely, we are still lacking the outcome data, but very likely significant endpoints, not only stroke, but also increasingly important dementia, cognitive impairment, anxiety, quality of life, and in particular, heart failure. Heart failure is the most common cause of death in patients with atrial fibrillation, not stroke. Also, we can reduce hospitalization, and therefore we think that early detection and treatment of atrial fibrillation may be cost-effective. How do we detect atrial fibrillation? It is the classical pathways through, for example, blood pressure monitoring, where the system tells you there's a possible arrhythmia. With modern devices, you can take an ECG and then have the diagnosis immediately at hand, or you can use handheld devices, or you can use consumer-initiated devices, apps, or wristbands, or smart watches, or the classical way of Holter monitoring up to patches and implantable loop recorders. That means many ways of detecting atrial fibrillation, and this is why we increasingly see atrial fibrillation and increasingly see atrial fibrillation early. Whenever we diagnose atrial fibrillation, we should think and manage this patient and individual along the multidisciplinary approach to atrial fibrillation management. And what you can see here from last year's guidelines, atrial fibrillation management guidelines, in the first place, it's the C in the AF care pathway. C for comorbidities and risk factor management. And at any stage that you identify atrial fibrillation, this is the most important task for you. And then comes A for avoid stroke and thromboembolism, R for reduce rhythm symptoms by rate and rhythm control, and of course, a repeat re-evaluation. And among the comorbidities and cardiovascular risk factors, again, hypertension in the first place, the strongest risk for atrial fibrillation and stroke after atrial fibrillation onset. So you need to address blood pressure besides all the other risk factors and lifestyle factors that have been related to atrial fibrillation, in most cases also to heart failure. So it is important to address those risk factors. Should we now go about and tell everybody to screen for themselves for atrial fibrillation? Of course not. I told you it's an age-related disease, and when we search systematically for atrial fibrillation before the age of 60, 65, this is not this will not provide a high yield. But on the other hand, if atrial fibrillation is detected and patients and individuals, before they get patients, consumers, use devices and detect atrial fibrillation early, there are opportunities through this earlier detection and then earlier treatment. This will also, the earlier detection and consumer-based detection of atrial fibrillation will expand over time the access to integrated health care. It will empower consumers and patients and hopefully increase education and cardiovascular awareness, because when you screen for something, you are aware of the disease and also of other underlying risk factors and diseases, very likely. However, there are also challenges to going and trying to identify atrial fibrillation early. We do not have the pathways currently for treatment, and there may be a significant healthcare burden if many more individuals enter the healthcare system with early atrial fibrillation or possible atrial fibrillation, because we will detect atrial fibrillation earlier in younger individuals with limited risk factors. There will be many false positives and also false negatives, and there are a lot of knowledge gaps today that we need to address before we should really go towards screening and very early detection of atrial fibrillation. So the take-home messages are clearly there are sex differences in atrial fibrillation onset, and effective risk factor management, treatment of underlying cardiovascular comorbidities should be started in both women as well as men, and this early detection gives us the opportunity to do so. To date, there is limited data and there are no clear sex or gender difference for the management of early atrial fibrillation. We need to have a careful balance of anticoagulation benefits versus bleeding risk. I showed you very early the device-detected atrial fibrillation populations, where the benefit of oral anticoagulation is much less than in clinically detected atrial fibrillation, the data we all know. But we have the opportunity, or need to take this chance, to slow progression of atrial fibrillation and thus reduce burden of atrial fibrillation. We have the opportunity for early rhythm control, for symptom reduction, and possibly for the reduction of future cardiovascular events. And with that, I would like to conclude, and I'm open for questions.
Thank you very much, Renate, for this excellent talk. And I invite you all to take the opportunity, go to the microphone, introduce yourself, and ask the question. While you are thinking about this, maybe I can start with a question for you, Alta. You talked about many different aspects related to sex and gender disparities, actually, in cardiology. But one that I, in a way, didn't pick up at least, was the role of editors and high-end journalists. Would you like to say something about that?
Yes, I think many of us who are on editorial boards of journals and editors-in-chiefs, I think that's also, of course, not equally distributed due to many pipeline factors, and that comes back to even women in positions in academia. So I did not even address the challenge of women in academia, and we know there's a lot of discussions in terms of family care, balancing life, home care, and often then when, for example, if both the husband and wives are both in academia, it's often not distributed equally, right? If children are born, it's the burden is often more a bit on the woman, and that's sometimes a natural development, right? So I think we also have to be cognizant that it will probably never be 100% equal, but we have to manage it the best way we can, and we have to acknowledge it.
There is a question over there.
Fiona Stewart from New Zealand. I'm very interested in the female-specific risk factors for heart failure, in that they're exactly the same as what we see for coronary disease. And do you think this is just a manifestation of coronary disease as a risk factor for heart failure, or do you think it's a different mechanism again?
I can start and you can fill in. I think it's well documented that if you have had preeclampsia, in studies that have used coronary CT angiography and looked at coronary artery calcium score, that these women have high level of coronary artery calcium score for their sex and age. So this is telling you that yes, they have an increased risk for coronary artery disease. But the first thing that many of these women meet, and not only for those with preeclampsia, but also for many of the other hypertension related disorders of pregnancy, is actually hypertension. And there is some evidence to think that there is a common pathway for many of these that goes through systemic inflammation, actually.
But in our data, population-based data, we indeed see earlier myocardial infarction, and then afterwards, as a secondary event, the onset of heart failure, also earlier in men compared to women. And women have less frequently coronary artery disease and myocardial infarction as a precursor of heart failure. So it's probably, again, this heart failure with preserved ejection fraction, which is more common in women and has different causal relationships.
Yes, and if I can also ask you, for women you expect hypertension disorders of pregnancy to be a contributing factor, but what about these under-recognized risk factors? Can you expand a bit on what they would be?
Those that were taken into this quite fresh publication, it's still only online, but it will come in Heart. They look from the UK Biobank. They looked at early menarche, they looked at early age for first birth, also for early menopause, and more the traditional, like female-specific. And then they also included like chronic inflammatory disorders in that group, which I personally don't agree with, I must say, because there's only 7 out of 10 patients with chronic inflammatory disorders that are women. So there is a sex bias, but it's not sex specific in my opinion. And if you look at type 1 diabetes or ankylosing spondylitis, actually that is more common in men. But to your question with these unrecognized risk factors, I think it lies in the title that we don't really know so much about these. But those that were mentioned in this publication from the UK Biobank were high deprivation, it was mental disorders like depression and anxiety, it was also low social economic status. And I think those were the most common. So they are less explored, actually. So it comes from being under-recognized. So I think it's helpful to start talking about it, that they matter for women's health.
There's a question up there.
Thank you all for a great session. My name is Esther Kringeland. I'm from Bergen, Norway. To you, Aletta, I just wanted to make a comment because, as you point out, we have less research on cardiovascular disease in women. But I think it's also a very important point that cardiovascular disease in women is under-recognized, both by women themselves and also by us as healthcare providers. So I think we have a very important job to do to increase knowledge among women and also among healthcare providers. And we have a lot of knowledge already, but we just have to take it into use in daily clinical practice.
Thank you. I think that's an excellent comment. I fully agree. And perhaps we should also think about medical schools, right? Start early in the training. I think once the bias is there to change that around later in life, it may be harder to do.
I very much agree with you, yeah.
So we hope that there will be many more efforts. They are increasing starting from medical school and maybe even earlier in teaching, educating people, kids at school about cardiovascular disease and potential gender differences and biases to improve the overall situation. And I like the last comment, and I think with that we need to close the session. We have come to an end. Thank you again for your great talks. Thank you for being here, and thank you for your patience and your excellent discussion. Have a wonderful remaining conference.